Fellow at the University of Rochester. So it's a 2-year fellowship that you do after you complete your training in neurology. And I chose to do this just to allow me to kind of better take care of people with Parkinson's disease as well as other movement disorders, especially get some experience with some of the advanced therapies that have come out more recently, which I'll talk about a little bit in this talk. Just a little bit about myself. So I actually grew up in the Middle East and then came to Rochester for college and sort of never left. It's become my home. I met my partner here as well. So I'm really looking forward to giving this talk. I take care of a lot of people with Parkinson's disease and really appreciate the opportunity to talk about it. Feel free to chime in with questions. I'm not going to take the full hour, so there'll be plenty of time for questions at the end as well. But yeah. All right. There we go. So in this talk, I'll talk about basic causes of Parkinson's disease. I'll also talk about symptoms of Parkinson's disease and how the diagnosis of Parkinson's disease is made. I'll talk about the types of treatments we have. I'll also address some common myths about Parkinson's disease. And lastly, I'll end with some reputable resources and sources of support that I recommend to people I take care of. All right, so first, what is Parkinson's disease? So Parkinson's disease is a progressive neurologic condition, and it results in progressive loss of brain cells that produce a chemical called dopamine in the brain. So dopamine is a chemical that is involved in regulation of movement, and the parts of the brain that are first affected in Parkinson's disease are the basal ganglia, so this is a deep part of the brain, as well as the substantia nigra, which is a part that's seen in the brainstem. So that's in the back part of the brain. So on the right here, you'll see a picture of the brainstem, and you'll see the specimen on the right is from a normal brain or a person without Parkinson's disease. And then the picture on the left is from the brain of a person with Parkinson's disease. And you'll notice the difference in that black staining between the two specimens. So the one on the right, like I said, is someone without Parkinson's disease. So that staining is for dopamine cells, and so it's more prominent there, whereas it's missing in the one on the right, on the left. And so that lack of staining means that those dopamine cells have died. And so this is, like I said, an indication of Parkinson's disease. And so when these cells die, and this is the chemical involved in movement, it goes to show that movement symptoms tend to be more prominent in Parkinson's disease. Over time, more brain cells do get involved, and that likely explains a lot of the non-motor symptoms that can also be part of this disease. So Parkinson's disease is the second most common neurodegenerative disorder. Okay. All right, perfect. Thank you. So like I said, Parkinson's disease is the second most common neurodegenerative disorder after Alzheimer's disease. It affects 1 million Americans and 10 million people worldwide. So pretty common overall. Men are 1.5 times more likely to have Parkinson's disease compared to women. We're not entirely sure why, but in consistent epidemiologic studies, this is a trend that we see. So next, let's talk about what causes Parkinson's disease. So there's no single identified cause, but there are certainly known risk factors, and age is certainly one of them. Most people with Parkinson's disease are over the age of 50. There's also clear genetic risk factors. So about 20% of people with Parkinson's disease are thought to have a genetic risk factor. And so what that means is certain genes have been associated with increased risk for developing Parkinson's disease, but it's not that everyone with this gene will develop Parkinson's disease, just a number have been identified. Like I said, it doesn't count for the majority of Parkinson's disease, but about 20% of cases is the estimate. And more genes are being identified with more research into this. There's also environmental risk factors. So it's now been known that pesticide exposure is certainly a risk factor for Parkinson's disease. There's a lot of advocacy being done in this area as well. Repetitive head injury can also be a risk factor. And then certain exposure to toxins, for example, Agent Orange, can also increase your risk for Parkinson's disease. So next I'll talk about symptoms of Parkinson's disease. And so, as I alluded to earlier, there's certainly motor symptoms of Parkinson's disease, but there's also a number of non-motor symptoms. So I'll start with the motor symptoms first. So there's one symptom here that is bolded. That is the one symptom that you need in order to have the diagnosis of Parkinson's disease. So everyone with Parkinson's disease has this one motor symptom, and that's decreased or slow movement. We call this bradykinesia. In addition to bradykinesia, you may have one of the other motor symptoms if you have Parkinson's disease. And so some of these other ones are tremor. So this is rhythmic movement of an extremity, stiffness of the muscles, also called rigidity, balance issues, may have freezing steps. So this is where people describe it as sort of feet feeling stuck to the ground, trouble getting started, especially getting up out of a chair, getting moving. Those tend to be common times to have freezing. Difficulty swallowing and drooling can also be an issue. This is because of involvement of the swallowing muscles. With limited swallowing, you can also have increased pooling of oral secretions, and that results in drooling. Softer speech can also be seen. So these are some of the common motor symptoms in Parkinson's disease. But again, the key one is really that bradykinesia. That's the one thing you do need for a diagnosis and that everyone will have. Then there's a number of non-motor symptoms. Now it's interesting, some of these non-motor symptoms can actually precede the motor symptoms of Parkinson's disease by years. We're talking even 10 to 15 years before motor symptoms can manifest. And those first three are the ones that I'm talking about that can actually appear pretty early. And so that includes decreased or absent sense of smell, acting out dreams, so kicking, punching, thrashing, yelling in sleep, and constipation. Now, on their own, not Parkinson's disease isn't the only cause of these symptoms, but especially when these precede motor symptoms, that can raise concern that you might be dealing with Parkinson's disease. Additional non-motor symptoms usually happen much later in the course of the disease, so after motor symptoms manifest. And those can include bladder problems, hallucinations, so seeing or hearing things others are not, changes in memory and thinking. The most common one I hear is word finding difficulty, just taking longer to get that right word, more than would be expected just from age. But the changes in memory and thinking, there's really a range in terms of what you might see. Depression and anxiety can also be pretty common. Drops in blood pressure, especially with standing, can be seen. And so this is because of involvement of the autonomic nervous system. So that's the part of the nervous system that controls blood pressure and heart rate, especially with position changes. So instead of the expected rise in blood pressure and heart rate when you stand up, these people may have a drop instead, and that can make them more prone to lightheadedness and falls. Decreased facial expression can also be seen in people with Parkinson's disease. So this is because of less movement of the facial muscles. And so it can sort of look like they have more of a blank expression, and that's part of the disease itself. All right, so now that we've talked about the symptoms of Parkinson's disease, let's talk about how the diagnosis is actually made when someone goes into clinic. And so Parkinson's disease is still very much a clinical diagnosis. And what I mean by that is it's not really based on a test, but really a physical examination and the symptoms that a patient tells their doctor. And the one symptom, like I mentioned, that you absolutely need for diagnosis of Parkinson's disease is decreased or slow movement, that bradykinesia. Plus, you must have one other motor symptom, plus various other symptoms, but you need at least those two things. In addition to have kind of supportive physical exam and a story that fits Parkinson's disease, the other thing I think about when someone comes into my office concerned about Parkinsonism is, are there other causes in play that may mimic symptoms of Parkinson's disease? And what I mean by that is there are certain medications, for instance, antipsychotic medications. These are medications that are used for specific mood disorders that can actually cause and mimic certain symptoms of Parkinson's disease. There's also strokes that can happen, in the basal ganglia. Remember, that's one part of the brain involved in movement. So if you have a stroke or damage to that same area that is affected by Parkinson's disease, you can understand how that might mimic some of the symptoms of Parkinson's disease. And so those are the things I also think about. It's important because depending on the cause, these people may or may not respond to some of the medications for Parkinson's disease, and it also affects whether or not I think these people will progress in terms of their symptoms. So people with what we call vascular Parkinsonism, for instance, or Parkinson-type symptoms because of a stroke tend to not have as much progression over time. Whereas someone with Parkinson's disease, as we talked about, it's a progressive condition with progressive death of those brain cells over time. So those people will have progression in their symptoms. So it's going to affect how we approach things, how they approach their life, etc. So it is an important thing to consider. Yeah.
Talk about toxins, medications, strokes as possible causes of Parkinson's. You go into which toxins might present.
Yeah, so Agent Orange is one that's been kind of found to increase that risk. MPTP is another toxin that we actually use to create mouse models of Parkinson's disease that's used in research studies to actually test therapies. Those are the ones that come to mind right now. In terms of medications, antipsychotic medications are the main one. Certain anti-nausea medications can also mimic symptoms of Parkinson's disease. The tricky thing is just those are also medications that can sometimes uncover symptoms of Parkinson's disease if you already have a tendency for that disease. So sometimes that's tricky to parse out. And so that is where actually these supportive tests can be helpful. And so, like I said, it's a clinical diagnosis based on what I'm seeing in the exam room, the story that I'm getting from the patient, but sometimes it's not clear cut, right? The exam is not, it's very subtle, or they're actually on a medication that I'm worried can be mimicking symptoms of Parkinson's disease. What do I do? So in that sense, that's when I think about these supportive tests. So there's two main tests I think about. I don't use these in isolation to diagnose Parkinson's disease, but when I have symptoms on examination that support, a possible Parkinsonian diagnosis, and I'm concerned and I want to make sure that I'm dealing with Parkinson's disease, then I order one of these tests because that provides another clue if they're abnormal that I may actually be dealing with Parkinson's disease. And the two tests that I think about are a DAT scan. So this is an imaging study, and it's specifically looking for abnormal dopamine uptake in the brain. So remember, that's the brain cells that die in Parkinson's disease. And this is abnormal in Parkinson's disease, but will not be abnormal in someone, for instance, if they're just having symptoms because they're on an antipsychotic medication. So that can be helpful. And then the more recently approved in the last year is the SYN1 skin biopsy test. And so this looks for an abnormal protein called alpha-synuclein in the skin. And so this is the protein that is thought to accumulate in the brain cells that produce dopamine and cause their death. And so in people with Parkinson's disease or those at risk, this can be elevated in their skin. And so I will send these tests if I'm concerned in those specific cases. I don't need these tests to make a diagnosis, especially when there's clear exam findings, there's no other causes I'm worried about. But when there's like a subtle exam or there's other potential causes that I'm worried about, this is when I might order some of these tests. All right. The next thing I want to talk about is rate of progression. This is a question I get from a lot of people in my clinic who come to see me because they have Parkinson's disease. They're worried about how fast the disease is going to progress. Unfortunately, this is probably the toughest question to answer. And the reason is because the rate of progression of Parkinson's disease really does vary from person to person. And it's different for every individual. And the best predictor of how far one person's Parkinson's disease is going to progress can be very different from somebody else. And so how fast they've progressed themselves in the previous years is the best predictor of how fast they'll progress over the next few years. Overall, in general, Parkinson's disease is a slowly progressive disease over years, but some people will progress a little bit faster. Others will progress a little bit slower, but typically still in the order of a number of years. You will hear about the Hohen-Yahr stages or scale. That's the one I have a picture of on that right side. It goes from 1 to 5, and you go up in stages based on whether one side of the body is involved or both sides are involved. It progresses depending on your change in ambulatory status, but you'll see you do need to have a significant change in mobility in order to go from one stage to the next. So I don't find this to be as helpful in day-to-day management of Parkinson's disease. It often is used, though, especially in research settings, so it can be helpful. But I don't find this to be as helpful in talking about rate of progression in general, because it doesn't take into account a lot of, for instance, the non-motor symptoms we talked about. If there's subtle changes in tremor that's really affecting day-to-day function, that's not really reflected in this scale either. And so I don't find this to be as helpful, but it is important to be aware of. Mm-hmm. Sure. Okay. I'll let that stay on the screen. You can see in stage 1, it's only one side of the body is affected, all the way to stage 5, where you need assistance for everyday activities, and people are wheelchair bound. So, like I said, it's pretty significant progression in mobility symptoms, but that's not always the only important thing for people.
Does everybody start out with one side of the body?
So typically, one side is more affected than the other. Oftentimes, I'll see some symptoms on the other side, but they can be pretty subtle or mild. So that's the most common presentation. I do have people who come in who've already had symptoms for years, maybe didn't know that they weren't really bothered by tremor, for instance, and so they didn't think to come into the doctor until years later. So those are the people who may have a little bit more symptoms on both sides. But usually in Parkinson's disease, one side tends to be much more affected than the other. It's an asymmetric presentation, if that makes sense. It's a good question. All right. Let me just go back in terms of the sides here. Okay. All right. Okay. So next, let's talk about treatment. So unfortunately, as a lot of you might already know, there's no cure, not yet, for Parkinson's disease. There's lots of people working on it and have been working on it for a while, but as of now, we still don't have a curative medication or treatment. And so in this case, exercise is really, really, really important, because it's the only thing in studies that is shown to actually help slow down disease progression. And the studies show that moderate aerobic exercise really helps slow down disease progression. And what I mean by that is something that makes you break out in a sweat, that makes it harder to breathe and difficult to talk while you're doing that exercise. And so I recommend to my patients 150 minutes of moderate aerobic exercise per week. But pick something that you can commit to and regularly do week from week. And that can be Parkinson's dance classes, rock steady boxing, brisk walking, anything that you can commit to like from week to week. That's important because the regularity matters. In addition to exercise, we do have medications that help kind of decrease the symptoms, help improve quality of life in that sense. But again, it's not a curative medication. The medications try to replace the dopamine that's lost, or it's trying to keep that dopamine that's still in the brain, keep it around longer. And out of all the medications that we have available, carbidopa-levodopa, brand name Sinemet, is still the best one that we have in terms of the most likely to help with symptoms and overall better tolerated than some of the other ones. We also use some supportive therapies for symptoms that carbidopa-levodopa doesn't address as well. And so just to expand on that a little bit, carbidopa-levodopa, the medication helps with certain motor symptoms, and specifically things like bradykinesia, or that slow movement, rigidity, or the muscle stiffness. and tremor, those are the symptoms that tend to be most responsive to the medication. Out of all those three, tremor is a little bit more variably responsive, but again, can still be responsive to carbidopa-levodopa. So those are the symptoms that, can improve with carbidopa-levodopa, but other things like balance issues, non-motor symptoms are much less likely to respond. And so that's when I think about supportive therapies to help with those specific symptoms. So physical therapy can help with balance, it can help limit falls. Occupational therapy is really helpful to develop adaptations for daily tasks, like for instance, if tremor is still pretty bothersome. Speech therapy can be really helpful, especially when people are experiencing really soft voice and that's affecting their communication. If they're swallowing issues, swallow therapy can be really helpful because people can be at increased risk for choking and subsequent pneumonia. All right, Kevin, should we take a break right now or keep? Okay. Sounds good.